I am Dr. PK, a board-certified internist practicing in California for more than 30 years. These videos are for educational purposes only. If you are experiencing chest pain, call 911 immediately. Chest pain is one of the most vital warning signs in all of clinical medicine. It is your heart muscle crying out for oxygen. Today, we are auditing the progression of ischemic heart disease from angina to a heart attack. Let's establish our baseline with angina pectoris. This is cardiac chest pain caused by ischemia, a temporary supply and demand mismatch. In stable angina, this discomfort is predictable. It happens during physical exertion or stress when the heart pumps harder against a fixed plaque. It completely resolves with rest or a nitroglycerin tablet. However, if that pain suddenly starts occurring at rest, it's unstable angina. This is a medical emergency signaling that the plaque is dangerously close to rupturing. When a plaque finally ruptures, a blood clot forms instantly, causing a myocardial infarction or a heart attack. In clinical practice, we split heart attacks into two distinct categories based entirely on your electrocardiogram or EKG. The first is a STEMI, an ST elevation myocardial infarction. This is the most severe form, representing a 100% complete occlusion. Because blood flow is entirely cut off, the injury spans the entire thickness of the heart muscle wall, triggering ST elevation. The second type is an NSTEMI. Mechanically, this is usually a partial or intermittent occlusion of the artery. While heart muscle tissue is actively dying, the downstream damage doesn't pierce the entire thickness of the wall. Instead, we diagnose an NSTEMI by identifying ischemic changes like ST depression and confirming elevated troponin in the blood work. In the management of an acute heart attack, our absolute clinical rule is time is muscle. The faster we restore flow, the more tissue we save. Immediate first-line management protocol relies on the classic acronym MONA. We start with chewed, non-enteric coated aspirin. Next, we deliver sublingual nitroglycerin to dilate vessels, along with supplemental oxygen and morphine to manage severe pain. For a definitive cure, a STEMI patient must go straight to the cardiac catheterization lab for a percutaneous coronary intervention, or PCI. A cardiologist threads a catheter into the artery, inflates a balloon to break the blockage, and deploys a drug-eluting stent. Our strict clinical benchmark is a door-to-balloon time of under 90 minutes. Otherwise, we must administer intravenous thrombolytics. Surviving the acute event is only step one. Long-term medical management focuses on stabilizing your vascular system to prevent a second event. We prescribe daily dual antiplatelet therapy like aspirin and clopidogrel to keep the stent clean and beta blockers to lower workload. High-intensity statins are used to structurally stabilize existing arterial plaques and shut down systemic vascular inflammation. To understand how to protect your vascular blueprint, explore our complete hypertension and heart masterclass playlist. Download my 14-day smoothie weight loss plan PDF linked in the description below. Subscribe and let nature help heal you.